Heikkilä, and I will be facilitating today's webinar. First of all, I would like to express my sincere gratitude to our speaker, Assistant Professor of Nursing, Dr. Mary Nevin, for joining us today. We are truly honored to have her as a part of our webinar series, and I want to thank her wholeheartedly for taking the time to share her expertise with us. I would also like to extend my thanks to all of you who are participating in this webinar, not only from across Europe, but maybe across the world. It is wonderful to see such a wide interest and engagement. Before we begin, I want to just remind you that all the webinar materials and the recordings of today's webinar will be available on our website afterwards. And at the end of Mary's presentation, there will be also time for questions. So please feel free to add your questions in the chat throughout the presentation, and I will collect them and address them either during the session or at the very end. And now let me introduce our honored guest speaker. Dr. Mary Nevin is an assistant professor of nursing at Dublin City University. She has been registered general nurse since 1999 and registered nurse tutor since 2005, with over 20 years of experience in third level teaching. Her teaching spans both undergraduate and postgraduate modules, including advanced clinical skills, biochemistry, research methods, and palliative care. Mary's clinical background is in medical, surgical, and palliative care. In addition to her academic role, she continues hands-on clinical work as a night nurse with the Irish Cancer Society, providing end-of-life care in home settings. We are delighted to have you here with us today, Mary. The floor is yours.
Thank you so much, Mina-Lisa. I'm going to share my slides now, if that's okay. Okay, I hope everybody can see that okay?
We see it
Great.
okay. Thank you, Mary.
Thank you, Mina-Lisa. First of all, I want to say sincere thank you for providing me with the opportunity to present today. I'm very happy to be here from sunny Dublin, which doesn't happen very much at this time of year. I'm delighted to see so many people present from all over Europe and indeed as far as India. You're all very welcome. It is quite strange just trying to present without faces. We did it for long enough during COVID, but the chat function is there. I'm very happy to take any questions, and I'll be keeping an eye on the chat, and I'll be asking questions throughout the presentation to have it a little bit more interactive for you. I'm also conscious that my native tongue is Irish, but I'm fluent English, and I tend to speak a little bit fast, as we in Ireland do. So I will try and slow down so that people can understand me well. But if I'm speaking too fast, please do tell me. Okay. So I'm here today to present on the second webinar of our series on knowledge for moral ethical leadership. I want to say, congratulations to the team of NursEduPal on some of the amazing resources that I've been accessing over the last few weeks on your website, and I would encourage anyone who has a bit of time to go in and have a look at some of the other resources. It really is fantastic, and it's a credit to you. And I'll certainly be using them and linking them during my teaching here in DCU. I am a nurse. I've been practicing since 99, and I do work clinically. My palliative care role is very much at the end of life. So my role is to go out to people's homes, because they choose to die at home, and typically we will go when people have less than 10 days to live. So it's very, very much at the end of life spectrum. My PhD in palliative care, I developed indicators so that hospital organisations can self-assess their level of integration of generalist palliative care. And I've been involved in primary studies as a principal investigator in populations of oncology and generalist palliative care integration and chronic disease and advanced nurse practice integration of palliative care in those areas. So very much in this space, and looking forward to present on communication ethics today. The presentation last week talked about principles of ethics, and some of you may have had a chance to look at that presentation. The purpose of today is to give an overview and an outline of what communication ethics is. People are very familiar with the concepts of communication and the concept of ethics, but how does this mix, and what do we mean, and what's the relevance, certainly within palliative care, about communication ethics? So I'll speak for about 35, 40 minutes, and then we can take some questions towards the end. Okay, so the learning objectives, hopefully following this presentation, you will have a better understanding of what communication ethics is about. You'll understand why communication matters ethically. You'll understand communication in palliative care, very much from an ethical viewpoint. And I'm hoping to take you through some of the commonly used communication tools in palliative care. And these will be familiar to many of you. And indeed, there may be others that you use that you might want to highlight to the group as well. These are some of the commonly used ones. And I can certainly talk about my experiences of using them as well, both in my education role and my practice. Okay, so when we talk about communication ethics, what do we mean? Well, obviously, any communication interaction should have ethical underpinnings, but why is it very relevant, certainly in palliative care? Well, it's because, there are often scenarios whereby you are communicating with members of the healthcare team or the patient or the family, where there are very much decisions that have to be made and judgments, around that communication as well. So, situations where communicating a care plan or a treatment to someone, you may have questions around that, in a situation where communicating care, or whereby a member of the medical team has communicated the care and maybe you have questions over how that was communicated or what was said. You may have questions around the integrity of yours or another member of the team's communication style or technique. You may have questions over whether yours or another person's communication was fair, was balanced. And I think very much from a palliative care point of view, was it truthful? And how was that truth communicated? You may have questions over yours or somebody else's responsibility or freedom to communicate. And I really think that that's a significant issue for us as nurses. I think many times we think about our role in communicating, but from interviews that I've conducted with many nurses, even at specialist level, we as a discipline can often feel constrained if a diagnosis or a prognosis is not given by a physician, and that can be challenging. Whose role, whose responsibility is it to talk about worsening condition and things like that? And also if you have questions whether your or someone else's communication is honourable, has that integrity and respects your ethical principles, your values, your virtues, and your discipline's virtues. And that can also, cause communication challenges. Ultimately, the purpose of this information webinar is to try and get you thinking, to be a little bit more intentional about how you communicate in a palliative care context, and to understand that our communication and how we communicate is very much underpinned by our ethical frameworks and our understanding of ethics and our virtues and our beliefs, and that impacts everybody when we communicate, who we're communicating with, who we bring into that communication scenario, and who we exclude. So I don't want you to get too comfortable. So we're going to ask people very early on, I just want you to have a think about it. You've come onto the webinar, you saw the title, so it certainly probably got you thinking of what does communication ethics mean to me in my practice personally. And as I've said, ethics and communication, it's always, a balance. Ethics is always about balance. And when we talk about ethics, it's about judgment and it's about decision making in a communication scenario. So if I was to ask you, what are your understanding, what is your understanding of communication ethics? And I'll give you a minute just to pop something in there. Or what do you think is a really important principle that underpins communication ethics? Very good. Excellent. So I'm seeing some lovely concepts coming through there. People talk about the principle of truth, of trust, dignity, respect for all parties, honesty, acknowledging and valuing others' opinions, cultures, and dignity, and active listening. Absolutely. Yeah. Okay. So what are we talking about when we talk about communication ethics? Reasons behind your communication, how you communicate. Very good. Speaking and thinking about complex situations. Very good. Let's move on to communication ethics. It does reflect two kinds of related goods, and people have alluded to it here in the chat already. Ultimately, for communication ethics, you have a substantive good. I mean, how I communicate with my patients is underpinned by my own ethical framework, by my own morals, my own compass, as you will, my own virtues, my own beliefs about what is good and what is reasonable. And these are significant, broader concepts, and people have already alluded to them: honesty, truth, respect, dignity. So these are very much substantive goods. But also, you need to consider how you actually practice. So what are the actual practices that you employ or that you are supported to employ to ensure that your ethical principles, that your substantive good is fundamentally part of that conversation or that communication piece. So communicative practices that ensure the active protection and promotion of a given good. Um, so if I was to say to you, of course, I'm looking at these concepts of honesty, of respect, of truth, you would say these are very all encompassing. But for me, how I practice that and how I communicate that through my language, through my words, through my body language could be very different based on your interpretation of dignity and what that means for you, or truth indeed. And that can be very internal, it can be very personal, but these are things that are also, issues according to our discipline, our worldview of what it means to be well or healthy or to be vulnerable. It can also be impacted by where we work, or the culture of the care environment we work in. These things can all have an impact on how these communicative practices are understood in practice. And often, particularly in the evidence around the acute care setting, nurses do report that there are tensions when they feel their moral ethics, their worldview of how they communicate with patients is not respected or is not afforded the same opportunity in the care environment that they think it should have. Like, for example, we're constantly hearing about metrics in acute hospitals and how we measure care, but how do you measure presence? How do you measure relationship? How do you measure the things that are really important to us as nurses? And these are often ethical tensions that we navigate on a daily basis in our practice. So what is good and what is right are central tensions, and they can be tensions that can be very congruent with your worldview. I mean, if you have substantive goods and you have practices that support that in your organization, that makes for a very good care environment. But it's important to understand when tensions do exist, and what is good and what is right, it can be very subjective depending on the context that you find yourself in. So it does depend. I mean, even looking at that picture, who sees 4 and who sees 3? We're all looking at the same thing, but we can have different perspectives on the same thing. So just consider there while I'm talking, what good does a person, group, or institution seek to promote and protect? I mean, I would hope that all of our care environments would espouse the values of honesty, integrity, dignity for our staff and for our patients. But in practice, how is that supported? And how is that communicated through how we communicate with our patients and our clients and with our other disciplines? So for example, here's an example. The central tenet here, the major good, is honesty and truth telling. I think many people here would feel that that is a significant central framework, ethical framework, if we're communicating with people in our care, to be honest and tell the truth. But in any given context, you may need to consider that and the value of being truthful and honest in a given situation. But within that, what are the practices that support you to be honest and truthful in your engagement and in your communication with your patients and with their families? So, for example, clear, honest, and compassionate disclosure of information would be one practice that would support that. So, if I fundamentally believe the people I look after have a right to be on, and I must be honest and truthful with them in all scenarios, then I need to ensure that I do always provide clear, honest, and compassionate information. I should explain things in language that somebody can understand, not use jargon, not use euphemisms, that create barriers to people understanding. Make sure that when the medical team discloses that I'm there, so I can translate and advocate for understanding in those contexts. Provide accurate updates on a person's condition, even when prognosis is poor or uncertain. So these are all practices that would support my fundamental underpinning good, which is telling the truth and being honest. Okay, but as I said, truth is not an absolute fact. And you may have a very clear view that truth and truth telling is fundamental, but it's how you apply that in your practices. I mean, for example, someone's histology is back and they go into their outpatient's appointment and they meet a physician who tells them their prognosis in a truthful, honest way. You have less than 3 months. It's terminal XYZ. And that person is left and they have very little safety netting, they have very little support provided after that, and they leave that scenario. Yes, that physician's has met their obligation to be truthful and honest, but it's not as much what you do, it's how you do it. And that's how do our practices support good ethical communication? Because in a scenario like that, for example, that person should have been contacted beforehand to bring someone who's a trusted friend or a family member with them to the appointment to understand the information that's given. Extra time should be given. Other members of the team, such as a nurse or a clinical nurse specialist, should have been present to be able to give further support in that. So that's one example of you can have a truth, but it's how you actually apply that in practice is really important. And whether your environment supports that or not can be something to consider as well. So that's the hyper good, and they're the example of the community practices that would underpin it. But that's just one example, and you gave me plenty of examples, such as dignity. If I was to ask you, well, I have a fundamental underpinning principle, a hyper good, that dignity is paramount for everybody I look after. Well, how do I apply that in my communicative practices? Throughout my career or throughout my interactions with the person I'm looking after, and how do I advocate for that dignity with the other members of the multidisciplinary team as well. These are all things to consider. So if I was to ask you then, what ethical values are especially important to you, and how do you express them through communication? Just give me one or two. When you think about communicating ethically, what's really important to you? What are the most important values to you based on your experience? And how do you express them? Autonomy, very good. Asking patient permission each time a procedure is done, irrespective of the situation. Very good. Very simple here, being led by the patient. Lovely example. Everything is led by the patient. Very good. Yeah, that's a very nice one. And autonomy is a really important concept. But again, it can be very challenging because we also have ethical and we also have legal obligations in caring for people, and that can certainly be very much within a jurisdiction of care. So while people have a right to autonomy, they don't necessarily have a right, to continue futile treatments. And it can be a balance. That ethical communication can be very challenging when families don't want to withdraw care and are against a decision that, it's in the best interest of that person to withdraw the care or to withhold the care. That can be similar as well, in relation to, I've come up with this issue many times in practice in people's homes where there's resistance to the use of morphine, and a patient may not be able to communicate with me at that point, but the family are quite resistant to me giving morphine, even though I'm seeing non-verbal cues that this person is in discomfort. So again, challenging communication situations, respecting the autonomy of the family to advocate for their loved one, but also understanding my role and my need to relieve suffering as well, and that balance of what should happen in a clinical scenario. And every time I come across it, the outcome can be different. Openness, sensibility, and communicate bit by bit, not everything at once. Very good. Absolutely. Recognizing that communication is never a one-stop shop, and it's often a very fluid and engaging process. When I look after people at end of life and their families, I could say the same thing 10, 20 times in one night shift about what normal dying looks like and what to expect, and reinforcing and being gentle and giving a little bit more every time, and, judging the people that I'm talking to in relation to how much they can absorb, their emotional capacity at that time to take on board what I'm saying, and balancing that with the need to be truthful and honest. And again, it's always challenging. To find out the most beneficial way for the patient, very good. And the importance of informed decision making, absolutely. And I'll come back to that really, really important concept, being informed to make good decisions. I think sometimes it can be very challenging for our physician colleagues to give truthful information about prognosis. And sometimes, particularly in the acute hospital setting, from the research I conducted, that can be very difficult to do. But I always view that from the perspective, if somebody doesn't know what they have left, how can they make meaning with the time that they have left? And actually, if you're not truthful and honest, you are depriving someone of the opportunity to develop their legacy, to make amends, to make sure people in their world know that they love them, and things like that. So, but it's how you communicate that prognosis in a truthful, sensitive, supportive way. It's also very heavily reliant on the concept of hope, I think. And if you talk about the concept of hope, a lot of healthcare providers would say, yeah, I don't want to take away hope. That's why we don't say things bluntly. But we do know from the evidence that, of course, if you're truthful and honest and you're imparting difficult news, that is difficult. Of course it is. You expect an emotional reaction. But we do know from the evidence that patients respond to that in a negative way initially, as any of us would, but ultimately it's a positive thing. And they will say, it was very difficult to hear, but I'm very glad I did hear it because I was able to do X, Y, and Z. And also the concept of hope is often misunderstood. You know, hope changes as an illness progresses. So at the early stages, you can hope for a cure, you can hope for years, but as you progress, that hope will shift to, you know, to priorities, to staying in work as long as I can, to being able to keep my independence for as long as possible, to being able to stay conscious for as long as possible. So hope does shift and change, but we can always meet people where they're at and get the most out of each situation by framing that hope in the context that's truthful and honest. But it is challenging. So why does communication matter ethically? Well, all communication acts as have an impact on everyone involved in the communication process. Patients and his or her significant others have a right to their own language and communication methods, and communicating ethically means that you recognize, you understand, and you make decisions about ethical issues, and that you're able to express them in an ethically sustainable way. And more closely in palliative care, we do know that palliative care patients and their significant others often experience real difficulty in communicating their true feelings, concerns, and needs. We can also see that, you know, differences in that as well between illness groups. So for people with chronic organ failure will describe this toxic positivity early when they, you know, enter hospital situations and everyone's happy in that, and they feel it's a barrier to being able to say, actually, I know you're all telling me I look well, but I don't feel well and I'm worried, because there's this positivity. People with cancer would describe, you know, reluctance to refer to palliative care. There's always another trial, there's always another round of chemo, and then when there isn't, what's left? There's a void. So it can be quite different for the different types of illnesses as well. But a systematic review published in 2023 by Engel et al. Looked at this concept from the perspective of patients and their significant others. Now, this systematic review involved over 50 primary studies, and what they found were 7 themes that patients and their families would identify as important. One is open and honest information. Um, there's this misconception that it's good not to be too honest and, you know, not to say too much, but people do want to know. They want it open and they want it honest. Aligning to the process of uptake and coping with information. So patients would describe, yes, I was vulnerable and I was anxious and I would like them to meet me where I'm at and give me information when I'm ready for it too. Empathy, of course. Most people in that systematic review, when they talked about empathy, it was about body language more so than the verbal instruction. So they felt that people were most empathetic when they displayed the correct body postures or language around that. Leaving room for positive coping strategies. That's where that concept of hope was identified in the systematic review, that they do have hopes. So, you know, and a lot of that was because the narrative at the time was there's nothing more we can do. You know, I'm not going to bring you forward for more immunotherapy or radiation therapy. It was very negative conversation as opposed to, you know, we're seeing significant progression now. So what's really important for you and how can we support you at this point in your prognosis and in your journey. So it's making sure that there is hope wrapped around coping strategies, and that, you know, healthcare professionals are committed and taking responsibility for these actions and these communications. And recognition of relatives in their role as caregiver. Again, within Ireland, legally, the only person that has any legal responsibility or autonomy over their healthcare is the person that you're looking after. Okay, so years ago we had a term called next of kin, and people were always asked who their next of kin was, and they were brought into all these conversations. But you know, it has no legal basis. The only relationship in Ireland a healthcare provider has is with the person that they're looking after. So if there's conflict around information sharing, and then the patient is the most important person in that scenario. There are situations where somebody can have a legal power of attorney, and that would be slightly different. So they would have legal authority over decisions, but in most cases, the only person that has the right for their own choices is the person, and not anybody else in their inner circle. So moving on to what makes good ethical communication. What are the major components of it? Well, there are three. And this was work done by Tompkins in 2023. So the three components of ethical communication are mindfulness, moral imagination, and ethical justification. So I'm just going to go through these slides here and just give you a general outline of mindfulness. It's a term we use a lot now in healthcare and outside of healthcare, being mindful. So what does it mean in the context of ethical communication in palliative care? It means being aware of your communication actions, what you say and do, and that you're aware of the people around you, who you're communicating with, and their surroundings and how it affects them. Like, for example, there would be times in someone's home where I would like to speak to the person on my own in a room, because often, particularly at end of life, they will tell me things they feel they can't tell their loved ones. So I always try and generate some time on my own, and then, have some time with family in the room as well. And if I feel there's a miscommunication about preferences, what's important, what needs to happen, I'll try and be that bridge for the evening while I'm there, just to gently nudge people down conversations, to try and align people's preferences a bit more. Being fully present in what we experience, do, or say, a mindful person communicates, listens, and is more aware of different viewpoints or perspectives, and more open to new information. Um, and again, I think we'd all like to think that we are like that. And I've no doubt as nurses, we definitely try and practice like that, but there are often constraints, and some of these are external. I want to be fully present, but I work in an acute hospital and I have this to do and that to do and that to do. And I also have curtains around the bed, and it's not conducive to being fully present or giving time or privacy that I need to have, an in-depth conversation. So being the opposite of mindful then is mindlessness, someone who has no or little awareness of what or how they're communicating, and of how their communication affects other people. That's the first component. The second component is moral imagination. Slightly different. So it's the ability to consider issues from different sides, especially from viewpoints that are different from your own. The ability to recognize and consider ethical issues from various perspectives, including people involved in the case. In communication, these viewpoints are expressed and verbalized. So the opposite would be nearsighted. I only see this situation from my perspective, from my role within my discipline, and that's how I communicate. And, it's a single perspective. It's from one's personal viewpoint. And again, if we consider, of course, I would like to consider things from different viewpoints, but how does that work in practice for me and in my organization? Again, my research in the acute care setting would say that all disciplines would feel they want to have other disciplines' viewpoints when they have meetings with families, but ultimately our care structures and our communication structures in hospitals are very challenging. It's difficult to talk to other professionals, to get multidisciplinary meetings, to organise family meetings with all the disciplines present. And care notes tend to be short statements. It doesn't really capture the nuances of people's preferences and what they want and the goals of care. It can be challenging. And then finally, ethical justification, the ability to offer justifications for ethical decisions based on moral and ethical principles. So the ethical justification clearly articulates the moral reasoning behind a difficult decision, grounding it in widely accepted ethical principles to explain why the chosen action is considered right or reasonable. The opposite is a rationalization, which is an argument that is based upon self-interest or poorly examined social convention. So, and that's Tompkins in 2023. For example, even going back in my practice years ago, I remember being a staff nurse in a hospital and very clearly seeing people who were at end of life, irreversible decline, days left. And I still see them being, prescribed medications. So for example, intravenous antibiotics or oral medications. And I would be chasing the physician, say, can we please stop these? You know, they're not needed anymore. We can clearly see this person is dying. But you know, it can be challenging to try and articulate that. And if you're told, well, just keep it going for another day or two, that's just a rationalization based on one worldview. You know, what I wanted was an ethical decision. I wanted a rationale that actually, no, this is why we're doing it. When I could understand the moral basis and the ethical basis for, you know, withdrawing those active treatments, but it can be very difficult in some situations to do that. So it's about 20 to 2. I have a few slides left just to provide you with an overview on the types of communication tools that are used in palliative care. I use these tools and I'm sure many of you do too. So it's just an overview, and there's plenty of further reading in the reference section if people are interested in finding out more about them. The first one I'm sure people are aware of. It's called the Spikes protocol. And it's just a tool to support people to frame difficult conversations or communication in an ethically justifiable way. So the first one is setting up the interview. And that's essentially making sure that if you're going to be talking to someone about a difficult ethical issue which requires some decision making and judgments, making judgments and calls on different aspects of care, that you do it in a private setting where it's comfortable, that everybody who's important in that scenario is in the room, you know, and that people have time to speak and people aren't interrupted. P is assessing the patient's perception. So, you know, trying to get an understanding of what people know already is really important as well. And it frames the discussion then to understand how much people do know and how much they do want to know. Obtaining the person's invitation. So in some cases, you know, people may feel they're not ready to hear everything. So, you know, would it help if I discuss this with you now? Would it help for me to kind of go through what we expect to see from your loved one in the next couple of days as they continue to die? You know, we can go through that and I can discuss that with you if that would be helpful. So, you know, getting the invitation out there and so that people, you know, are on the same page about how much they want to know. And then giving that knowledge sensitively, carefully, and making sure that, you know, you're checking for clarity. You're addressing the person's emotions as well, E, with empathetic responses, so that if someone responds in an angry way, that you acknowledge those emotions, you know, and most of the time people just want to be acknowledged. You know, I'm really angry. I'm really angry. I thought I had longer. Or, you know, I'm really scared. You know, is she in pain? So, you know, mirroring those emotions and saying that back is really useful. And then obviously that strategy and that summarizing what was said, what was understood, and making sure the person always feels that they can approach and discuss it again. This is a tool I use a lot with my undergraduate nursing students in a role play scenario, and they get a huge amount out of it. If you're interested, you can download the Spikes protocol from that web link. Everybody knows what active listening means. It's another tool that is really good for communicating in palliative care. What does it involve? And I think everybody could probably attest to this. Full presence, paying complete attention and demonstrating genuine interest through verbal and non-verbal cues such as eye contact, nodding, facial expressions. And that can be a really difficult concept. You know, how can you be fully present in someone's care, you know, depending on the other work that you're doing, the environment that you're in. But it is about, you know, the quality of your interaction with someone. It's not necessarily about the quantity. And I think in acute hospitals, we're so quick now to put people in single rooms when they're dying. It can be very difficult to be present. to be in there without actually having to do something, just to be in there to talk. But, we do know that the vast majority of our communication skills are through our non-verbal cues. So, I mean, using good communication techniques, eye contact, nodding, facial expressions, to demonstrate our presence and our empathy is really important. So empathy and reflection, understanding and accurately reflecting back the person's feelings and thoughts. I mean, the amount of times I will go out to someone's house and you walk in and you can just feel the tension, you can feel the anger, and it's different members of the family. Some people are upset, some people are still wondering why, some people are very angry, and you're trying to meet people where they're at and reflect and mirror those emotions and empathize with them. And also, trying to get across as an educator with my undergraduate students is it's okay not to know. People often don't expect you to know or to have the answer, but they just want to know that you're listening. They want to know that you kind of get where they're at, that you can demonstrate some empathy, that you can say, you know what, I have no idea how difficult this must be for you. This is your mother, this is your husband, this is your child, this is devastating, and I'm just so sorry. Even just being vulnerable and just being able to say that is hugely powerful in that trusting relationship we as nurses build. Open-ended questions and encouraging people to express their concerns and emotions freely and fostering deeper conversations, most definitely. From my experience, every single reaction to grief is normal. Everything is normal. I have seen everything, and they are emotional reactions. And I think as nurses, we are very good at seeing the whole person and staying with that. And I'm very lucky that I look after people in their own homes, so they're much freer to express their emotions than they would be in an outpatient's clinic or a hospital environment. And I always say that if I'm doing my job well, I'm wallpaper. So what does that mean? It means that if I'm doing my job well, that I am just fostering conversations, nudging, supporting, coming in when needed and moving back so people have their own space. A bit like a referee in a match. I often say to my undergraduate students, if you're doing a good job, nobody notices you're there, but you are just supporting and making sure people are getting the most out of the time they have together. Non-judgmental attitude, of course, so avoiding assumptions, and courageous dialogue, having the courage to discuss sensitive topics such as fears related to dying openly and respectfully. And I suppose that's something I'm very comfortable with because in my job people are dying actively, so it's part of my normal narrative. But it can be difficult in other settings, and certainly where there's a change in the condition and a shift in prognosis, that can be challenging. But I always tell our students here that the worst thing you can do is have people thinking they have a lot longer than they have, because now you are depriving them of what they need. Okay, so I want to know from your perspective and your experience as nurses, what are the barriers to active listening that you have encountered? And that can be institutional, it can be personal, it can be skills, it can whatever. The first one that came in very quickly there is workload. Very good. I completely get that. And I remember having that conversation with someone who was developing the metrics for an acute hospital about how they measure nursing care, and some of those metrics. And they said, well, look, we measure it by X, Y, and Z. And I said, well, look, you have to remember that what you measure is what you value. And we have to understand how we value presence. And if all of the metrics require you to be doing the meds, updating the care plans, the wound care and all that, and there's no room left for the really important stuff that helps people to heal, not necessarily to cure, and that's that presence, that's that relationship, that's that communication piece, then, your organization will be perfectly designed for what it gives. And it is difficult to look at how we measure that and how we value that in care environments. But absolutely workload, there are always pressures on our work. Preoccupation with personal issues and biases. Oh, most definitely. I always say that, you know, particularly at end of life and doing end of life care all the time, you know, we're dynamic individuals as well, and there are things that go on in our personal life, and there are times I'll go out to a house and I'll find it very difficult because it resonates with me a lot more than other houses. It could be someone that, you know, reminds me of someone in my family, or it could be a very young person dying with children around them, and that can be quite difficult. So our ability to be present and to give really good care can certainly fluctuate based on our vulnerabilities and our ability to be vulnerable as well. Trust policy for taking notes at point of contact, having a laptop out in people's homes, writing and then talking. I refuse to do it. Yeah, that's a really good point, Adam. Thank you for that. I mean, how many times have you gone to your GP and you're trying to talk to them and they're facing their computer and they're writing what you're saying onto their PC? It doesn't feel like there's a very good connection being made. Speaking more than listening. Really good, Andreas. Thank you for that. And my own assumptions while I try to quiet them down. Yes, thank you, Melissa. It's impossible to separate us as a person and who we are culturally, and our experiences of life and of death. It's very hard to separate that from every encounter with a person we're looking after, and that's the self-awareness piece. It can be challenging. But there are plenty of barriers there, of course. Workload, distractions, yeah. Okay. The last thing I wanted to mention around communication tools for palliative care is dignity therapy. This was was a researcher. He's a researcher in Winnipeg in Canada. Harvey Chochnov, and he is a psychiatrist and he's an eminent author, researcher in the concept of dignity and suffering. And he developed a framework for dignity, and it's very, very widely used. And it's about creating a narrative document for a person and their family who's dying that gives them the chance to reflect on their life experiences. And by doing that, it can reduce psychosocial and existential distress among people with palliative care needs, and it can assist the person to discuss issues that matter to them most. Discussions can be transcribed and edited so the person can pass it on to their significant others. So it's a really fabulous way of legacy making towards the end of life. And using this method requires prior training to some degree. There are some really, you know, good concepts and trigger questions that I use all the time in my practice. But, you know, it is useful to get some prior training as well. And you can utilize some of it as well. You don't have to use all of it. So what do I mean about questions? I mean questions about someone's life. So, you know, it can be really useful just to start a conversation about, you know, tell me a little bit about your life history. You know, are there specific things that you want your family to know about you? Are there particular things that you still feel that need to be said? And what are your hopes and dreams for your loved ones? What have you learned about life that you want to pass along to others? That's just an example. There are many other questions that can frame a really deep and meaningful conversation between family members, particularly towards the end of life. For me in practice, there are many times where I will see people who maybe to an extent are clinging on to life. They are dying, but it's taking longer, and the family are exhausted, and they often have many physical symptoms. And I will often ask the question, do you think there's anything that maybe needs to be done or said for your mom or dad? You know, do you think maybe they're holding on for something? And, you know, you can still, you know, do many things to support that. Talking to people after the consciousness has gone, there's loads of things that can support people for, you know, a comfortable and peaceful death. And also from my practice, I find that using these questions, you know, you can support a family even with very little time left. You can support a family to make some meaning at the very end, and, you know, to make amends, to get forgiveness, to tell people how they feel about each other. It can be very, very emotionally enriching, even at the very end, even when there's hours left. Okay, so that was just a whistle-stop tour of some of the communication tools that are used in palliative care. There are plenty of resources there if people are interested in reading further about that. I've just put them in really small font. It's something that you can get and you can maximize as well. I hope it's been useful. I just wanted to say, Gurmeen Mahagwif Galer, a very sincere thank you all for listening to the presentation. As I said, there's plenty of other resources there. There is an e-course in development related to this content that will be released later of the year that will provide extra resources and some activities that you engage with around this topic. And I've had I've been able to have a brief look at it in its development, and it's really going to be something that's very useful. So you can look back on that. So I just want to say thanks sincerely for being at the presentation today.
Thank you so much, Mary. This was really clear and inspiring presentation. There are many claps and hearts coming to your way.
Thank you.
You highlighted really well the complexity and also, I think, the importance of the communication ethics. It was really nice to hear your from the research and also from your own clinical experience, the examples like the wallpaper and being one, how to become one. While the others, we can ask you some questions, but still, while the others are formulating, then maybe can I ask one myself?
Yeah, of course.
You gave us a lot of the experience and examples, but what has been the most meaningful or memorable experience for you when teaching or practicing communication in palliative care? Do you have anything you want to share with us?
Well, I think there's a big difference between undergraduate and postgraduate nursing and how we teach communication. So in our undergraduate curriculum here in DCU, we have a spiral approach. So we give the early concepts in first year and we build upon that in their subsequent years over their 4 years. But I have those students in third year, and I do a significant portion on communication using the Spikes tool. And the value of the Spikes tool for undergraduate education, I find, is very much to support early stage student nurses in communicating with patients. They find it very difficult to go into scenarios where they don't feel they have the knowledge. And they're not used to communicating with people who are not of their own age group. And they're certainly not used to communicating with people who they know are suffering. And it's difficult to be present when you know they're suffering, and that's the challenge, and it's to try and give them a good framework that they can go in and say, okay, well, I can go into this single room and ask how everybody is and just be with them, and they have that in the background. We use role play a lot, and that really does help. Putting them into just scenarios, vignettes, and asking them to role play with each other, examples of good and examples of poor techniques. And they really do get a lot out of that. And you can see their confidence improve in how to actually communicate with people who are dying. And their families. So that's the use of the Spikes. I would use that also in postgraduate. So I chair a program in specialist nursing here, and as part of that, I've developed an optional module, a master's module in palliative and end-of-life care, generalist palliative care. So I would use the Spikes, but the scenarios that I would use would be more complex. It would be evidence-based, based on what nurses typically describe as frustrations in communication ethics in palliative care. And very often this is framed about miscommunication with the other members of the multidisciplinary team, and often with physicians, about truth telling, about recognizing dying, about whose role and whose responsibility is it to talk about prognosis, about withholding treatments, and that moral distress when they feel that there isn't alignment with their values. So the communication vignettes I would use in post-registration would be much more centered around the multidisciplinary team, and how they would address that and how they can advocate for what they do see in practice. So yeah, and we're going to trial a VR intervention with that group using virtual reality, and to get some feedback on a pilot intervention for the postgraduate students this year. We're at the moment we're scoping some software packages to see if that might be helpful as well. So that's my experience of teaching communication in the undergraduate and postgraduate. Certainly from a clinical perspective in my role at end of life, I've found Harvey Chupchoff's work and his trigger questions really useful, like really useful. And I think what I've learned most over the probably 11, 12 years I've just been doing that work clinically is all good communication starts with questions. Like the more questions I ask at the start about, goals, about what's important for you right now in your home with John, whatever it is, and their values and what they want, loads of those questions really is the basis for all the communication I do after that, because then I can be absolutely sure it's what they want and I'm trying to remove myself from that situation. I
Thank
don't know
you
if that's
so.
answered your question. I hope
Yeah,
so.
yeah, and a lot more. I think we get also tips for the teaching part and also for the clinical part. So that was perfect. Thank you.
Thank you.
Here are some questions from Dr. Shani.
Okay, I see communication is 70 to 80% non-verbal. We focus on verbal communication. What has been your experience in teaching novice nurses in this regard, especially when they are very young and have no life experience, and what are the cultural barriers? Very good. Thanks for the question, Dr. Shani. Okay, the first thing I would say is in those undergraduate vignettes that we use, we always preface it by exactly the percentage you discuss about verbal versus non-verbal. We ask them roughly how much do you think is verbal and how much do you think is non-verbal. And then we set up scenarios whereby we create a really poor non-verbal scenario. We ask someone to go and talk to a patient, stand over them, not give eye contact, have their sheet out and be talking, and then, and get them to basically reflect and critique the scenario. Sometimes we'll bring staff in to do that, so they don't have a clue what's happening, but they can very clearly see a poorly structured communication in it because of the non-verbals, and they really do get that. And then we ask them to critique the care environment. What are the issues that crop up so that your communication is hampered? And they're very good at feeding back around that. So we always put a huge emphasis on the non-verbal in the undergraduate, most definitely. And what are the cultural barriers? Well, I would say in Ireland, about 85% of our population still identify mainly as Roman Catholic, and I would say that's in part to the limitations of how our census is generated, and we just ask questions of were you baptized, not do you currently practice. So our nuanced questions aren't there, but we also have a population that is about 15% non-Irish migrant population. We have a huge amount of people who are aging in our and our workforce, our healthcare workforce, is very much multicultural. So I would say, from my perspective, yes, there are cultural barriers, but I have found it a massive enriching experience, working with people of different cultures and understanding their perspectives of what living and dying is. And I find that really, I remember 20 years ago in Ireland, we had a lot of Filipino nurses that came over, and, understanding their practices at the end of life, leaving windows open, taking out mirrors out of a room. I was fascinated by it. Why do you do all this? And it was very, very, very much a rich learning environment. And then many of our colleagues are now from India and from South America. And again, understanding those care practices, those rituals associated with death and dying are really, really powerful. I remember 20 years ago as well, every hospital ward had a book, the big book, and it was like a menu. Islam, Jewish, Hindu, Roman Catholic. This is what you do and this is what you don't do. And I think now we understand, and the evidence shows us that you got to throw that out. Everything begins with a question. you know, what's important? What would you like? I can see here that you've identified as Jewish on your care plan, but you know, what does that mean for you? Who would you like us to have here? You know, I understand that your loved one will need to be washed by the same gender. Let's make sure we can facilitate all that for you. You know, I go into houses and people will, you know, people will talk about being Roman Catholic, but they don't want a priest in the house. They don't want, you know, certain rituals that I would have associated in Irish culture of what's important. Ultimately, it's very person-centered. But there's no doubt culture can be. It absolutely can. You know, do I believe death is the beginning of life, or do I see death as the end? You know, that can frame how I can discuss it. You know, do I subscribe to a deity? Do I not? You know, if my conversation around reassurance is it's God's will, well, that wouldn't be terribly comforting in the wrong context. So most definitely they can be barriers, but I think we are getting better. We have a long way to go in getting more culturally competent and making sure that our environments are culturally sensitive as well, that we recognize people's differences, and that at the end of the day, it all begins with what's important, what do we need to do for you. I have another one here. I think the idea of ethical resilience is an interesting topic. Learning from situations when your ethical decision making is questioned, especially for undergraduate or newly qualified nurses. Have you come across research on this? Yeah, like, I mean, there's no doubt there's a body of evidence there, and it's feminist theory. It's about care ethics. So traditionally, healthcare ethics was based on the medical model of beneficence, maleficence, and do no harm. It was very structured. It's very, you know, seems very clear cut, you know, black and white. But there was research done, and it was the Hines trial. And I won't go into it in detail, but it was an ethical scenario where children were asked to comment on a situation whereby someone had to do wrong to ultimately get something right out of it. And they found major gender differences in that. And his PhD student at the time took that forward, and there's a huge body of evidence now recognizing that gender has a big influence on ethical decision making, that females tend to be more nuanced, that because you know they tend to look at personal relationships and consequences in those categories, they can be a lot more nuanced in their ethical decision making. So we know to make good ethical decisions, you need to have a balance of disciplines. There should be different gender views in that room as well. And we also need to understand that nursing, our unique worldview is relational. Nursing's relational. So, you know, there's one thing making a decision, an ethical decision based on your responsibility to do X, Y, and Z, but you know, nursing is built around connection. It's about emphasizing the understanding of different contexts. It's about trust and collaboration between nurses and patients. So our worldview is always going to be grey in all situations. It's about the judgment and balance in certain situations. So care ethics is a very well-defined feminist theory if someone wants to read a bit more about that. And it's something that we teach in our master's program here. And we use some of the other excellent resources around moral case deliberation to support nurses in that type of regard, so that they understand that, you know, we have a voice, and it's just as important as the Hippocratic voice of our physicians. Was there any more questions?
I think that was the last one from Adam, and I'm really delighted that we get to share your expertise at this topic. Thank you so much again, Mary.
No
And
problem.
I think I will hand to Patricia now.
Thank you. Thank you, Mina Lisa, for facilitating this session. And all I could say is thank you, Mary, for your informative and really, really interesting webinar. We've really benefited from your clinical and academic expertise. So, Gura Mila Mila Mahagut. I'd like to just invite you all. I'd like to just inform you all of our next webinar, which will be happening next week. So please keep in touch with our website and our LinkedIn. We will have details of that from tomorrow on how you can register. And then most importantly, if you would like to download the certificate of attendance for today, it's available there using that QR code and the link that's there. This also leads you to an evaluation form where you can evaluate today's webinar so that we can learn from that and to be continuously improving and offering from the ideas that you give us. So thank you so much for that. I'll leave up this slide for you for another minute in case you just need to take down any details. And all it leaves for me is to thank our facilitator, our presenter, but most of all to thank our attendees for coming today. And we hope to see you again next week. Thank you.